Good evening, everybody, and welcome to the first ever cross specialty panel discussion on use of Elobixibat in treatment of chronic constipation. Our agenda for today will be introduction and context setting by me. I am Dr. Pragati Srivastav, the medical advisor from DRL team. We will then have a talk by Dr. Sukhresh Sood on the clinical trials on Elobixibat, the Indian and global perspective. Following which, we will have a panel discussion on the real world use with the cross specialty team of Dr. Radhi Sood as the moderator, Dr. Sukhresh Sood as a panelist with the gastroenterologist specialty, Dr. Manish Jain, Dr. from nephrology, Dr. Sanjay Mittal from cardiology, and Dr. Jasjeet from endocrinology. We will then have a conclusion and take home messages by Dr. Radhi Sood. A little background on chronic constipation and Elobixibat. Chronic constipation significantly impacts the quality of life for many adults, with available treatments typically focusing on just one mode of action. This often leaves a patient with unmet needs, as these treatments may not provide a complete and holistic symptom relief. With Elobixibat as a first-in-class bile acid transporter inhibitor, it stands out with its dual mechanism of both promotility and prosecretion, thus offering a significant advancement in the treatment aspect. This panel discussion will explore why Elobixibat presents a breakthrough in the chronic constipation management and how it is backed by the clinical evidence that demonstrates its efficacy and safety in improving the patient outcomes, and how at different specialities the drug will help us in giving a holistic symptom relief to the patient. Our chairperson for today is Dr. Randhir Sood. Sir is the chairman at Institute of Digestive and Hepatobiliary Science at Medanta Hospital, Gurgaon. He has more than 30 years of experience and has established two large GI centers of excellence in North India at Sir Gangaram Hospital and Medanta, Gurgaon. Sir has pioneered various treatment options in the field of gastroenterology, gastrointestinal cancers, and hepatic diseases. He also has numerous publications under his name. Our speaker for today is Dr. Sukhresh Sood. Sir is the Senior Consultant Gastroenterology and Interventional Endoscopy at Medanta, Gurgaon. He has done his fellowship at Advanced Endoscopic Surgery at West China Hospital, Chengdu, China in 2019. He has been awarded the gold medal in his DM Gastroenterology in 2018 and has been placed in the second place at TYSA Gastroenterology India in 2017. He has also been awarded the Best Endoscopy Video at IDDF Hong Kong in 2023, as well as the Best Endoscopy Video at ISGCon Bangalore in 2023 again. Our panelist for today, our first panelist, Dr. Sanjay Mittal. Sir is the Vice Chairman, Clinical and Preventive Cardiology at Cardiac Care Medanta. He has done extensive training and experience working at various institutes in USA and in other locations such as Buffalo, New Hampshire, Italy, as well as Germany. Sir is currently in charge of the heart failure program, non-invasive and clinical cardiology, as well as the clinical research program at Medanta at Gurgaon. He is also the director of Medanta Duke Research Institute and has more than 50 publications in various national and international journals and textbooks. He has also been a part of various clinical trials. We would also like to welcome Dr. Manish Jain. Sir is the Director, Nephrology and Kidney Transplant, Renal Care at Medanta. He has done his clinical fellowship from University of Columbia at Vancouver, Canada. He has expertise in renal disorder with a special interest in the renal transplantation and dialysis. He has been awarded the FICP by the Indian College of Physicians and FISN by the Indian Society of Nephrology for his outstanding work and continuing services to the society and community. Sir has published and presented more than 50 articles in various books, journals, and various conferences. We have next Dr. Jasjeet Wasir. Sir is the Director of Endocrinology and Diabetes at Medanta. He is the primary faculty for the Center of Diabetes Therapy and Technology. And under the guidance of Dr. Ambrish Mittal, he is spearheading the weight management program at Medanta. His areas of expertise include weight management, diabetes, and heart attack risk factor assessment and control. Sir also has numerous publications in various high-impact international national medical journals and has presented his original work at national and international forums. I welcome you all to this panel discussion, and now I hand over to Dr. Sukre to take us through his presentation. Over to you, sir.
I'll just share my PPT.
Yes.
It visible?
No, we can't see
Not
it.
yet, sir. Yes,
Yeah.
it is
Yeah.
visible.
So, good evening, everyone. And thank you, team Dr. Reddy, for the opportunity to speak about a new molecule when it's evident. We'll be going through its evidence and its role in chronic idiopathic constipation. So we know it's a relatively safe and efficacious new molecule used in chronic constipation. There are two phase 3 studies in chronic constipation carried out in Japan. There's two studies. First study was a randomized, well-developed double-blind placebo-controlled trial, 70 odd patients of chronic constipation according to the Rome 3 criteria, given treatment with Elobixibat for 2-week period. 5 milligram, 2 tablets a day. That is what we also prescribe in a 1:1 placebo-controlled manner. And we studied the change in frequency of spontaneous bowel movements. The second study is an open label long-term safety trial, which included these patients alongside 340 total patients were included over a course of 52 weeks at different dose groups, 5 mg, 10 mg, and 15 mg a day. And the safety was assessed in terms of adverse drug reactions, the incidence, severity, and types. So it showed in this group fast and sustained relief. In 59 odd patients, that is 86% of the cohort, the patients had their first spontaneous bowel movement within a day. So this is a good basically benchmark for any drug where we are seeing early efficacy for SOS use. And the median time to first spontaneous bowel movement was around 5 hours. So this sometimes becomes an issue as well. Some patients may have very rapid spontaneous bowel movements. So you have to time the drug accordingly at after or around the dinner time. And then the patients, around 46% had their first complete spontaneous bowel movement within 24 hours. And the median time to first complete spontaneous bowel movement was around 9 hours. So the mean number of weekly spontaneous and complete spontaneous bowel movements were increased and sustained from baseline throughout a 1-year period in the safety cohort. So it showed to improve bowel movement frequency as well as the Bristol score, which tells us about the consistency of stool. In India, our patients usually have a range between type 3 to type 5 considered as normal, as per the Indian version of the Rome criteria, and it had an average mean consistency at weeks 1 and 2 of 4.3, which is as close to ideal as you can get. And the proportions of weekly responders increased and sustained throughout the 2-week efficacy cohort. The constipation severity also improved more with Elobixibat vis-a-vis placebo over the 2 weeks. Then they studied improvement in enhanced quality of life and patient satisfaction scores. So at different time points, 4 weeks, 3 months, 6 months, 36 weeks, and 52 weeks, they studied the quality of life scores and they showed significant improvement across different timelines as compared to placebo. And the satisfaction of bowel movement scores were also improved compared to those at the baseline in the safety cohort. So it was found to be safe in terms both short-term and long-term use. The most common adverse drug reactions were abdominal pain and diarrhea, which resolved within 1 to 2 weeks. And of the diarrhea cases, 60% odd resolved without any changing in the dose, and a fourth resolved by some dose reduction. Elobixibat had no deaths or severe adverse reactions in studies up to a year, confirming its long-term safety. And it was primarily eliminated through the feces itself, hence minimal absorption, hence minimum avenue for adverse events, and only 0.01% was found in the urine. It acts locally in the lumen and minimally absorbed in the bloodstream, and thus has a low risk of systemic adverse events, which was shown in the safety cohort. It outperformed placebo in enhancing bowel movements in this Indian cohort as well. This was a study conducted in multiple centers, primarily led by DMC Ludhiana, Dr. Umesh Goyal's group. And this was prospective multi-center RCT, which had 76 odd patients in the drug group and 74 in the placebo group. Elobixibat had increased weekly spontaneous bowel movement frequency more than placebo, significantly more. And more patients had a complete spontaneous bowel movement response with Elobixibat vis-a-vis placebo. It accelerated the bowel movement onset also in the Indian cohort, and more patients had a spontaneous bowel movement within 24 hours, and even shorter median time to first bowel movement as compared to placebo group, which was 11 hours versus 22 hours median time. It is well tolerated in the Indian patient with only 1% instance of diarrhea, which is better than what the Japanese cohort has shown. So of the 150 patients included in the safety analysis, 15% had reported at least one adverse event, out of which 2.6% had some dry mouth, 4% had some distension, 8% had pain, and only 1.3% reported diarrhea. Hence, it was well tolerated with no significant safety concerns over a 2-week period of once a day dosing. And this study, published a couple of years ago from a Japanese group, demonstrated both safety and efficacy in elderly patients, which is the most common subgroup that we deal with on a daily basis with chronic idiopathic constipation. So the elderly groups were aged between above 65 and above 75. Two subgroups were made, and they had significantly more bowel movements weekly and higher mean spontaneous bowel movement scores at week 2 and 4 compared to the baseline. And it appeared to be well tolerated also in this subgroup, with only around 4.5% of the patient was 65 years and 3.5% of the age of 75 reporting any adverse drug reactions, of which diarrhea was followed by pain abdomen. So it improved in this study, it improved the scores in constipation patients again in the elderly subgroup, and they want to investigate the role on the rectal sensory threshold, which they study with anorectal manometry. And the patients who had preserved desire to defecate showed significant reductions in their total constipation load, and also the anorectal manometry parameters had significant improvement compared to placebo. This showed safety in patients with comorbidities is the most important for rest of the doctors. So in diabetics, instead of adverse events, total was 3%, out of it mostly was diarrhea. Impact on quality of life was improved significantly over both to 1 and 2 months, and spontaneous bowel movement frequency increased to 6 per week on average, and their overall stool frequency scores were also increased. Renal disease patients, adverse events were around 4.8%, diarrhea was 2.5%, and spontaneous bowel movement was around 1 per day. Heart failure patient also had higher adverse events, around 17%, and spontaneous bowel movement were also around 4 per week. In patients suffering from cancers, their adverse events were also not very high, 6%, and they were also getting 1 bowel movement per day. Parkinson's variant patients had high adverse events, around 56%, and spontaneous bowel movement were also hovering around 6 to 7 per week. So the drug also reduces reliance on further SOS use of saline laxatives or stimulant laxatives. So they studied the continuation need for stimulants or saline laxatives during treatment with Elobixibat in 11,000 odd patients. Again, this data came from Japan. The proportion of stimulants and saline laxatives decreased from the pre-index to index dates, and half the patients stopped completely these laxatives 1 year after the initiation of Elobixibat. Hence, they concluded that starting this drug notably decreased the need of these additional laxatives per year and providing valuable guidance on managing real-world cases of chronic constipation. So dose escalation did improve severe constipation without a relative rise in the adverse drug reactions. This was a study again from Nakajima's group in Japan with weekly increase in bowel movements across different subgroups of severe, very severe, and absolute constipation. More patients in this worst subgroup were titrated to the highest dose, 15 milligrams per day. And the proportion of patients who were still taking 15 mg in the last 4 weeks of the 52-week trial had increased, and no notable increase in adverse drug reaction was seen despite the dose escalation. So again, it was well tolerated at dose up to 15 mg for 2 weeks. So we even in our patients, sometimes we start with 10 mg, but we may have to escalate to 15 mg. And this study showed that increasing the dose did not, over a short period also, did not affect the in terms of adverse events, was well tolerated by the patients, and we could achieve spontaneous bowel movement even in the refractory constipation subgroups. Some additional insights. That not only it helps in constipation, but Dr. Wazir would be interested to know that improves the glucose and lipid metabolism as well. Hence, in this single-arm pilot study, which was conducted again in Japan and published 2 years ago, they administered 10 mg per day dose for 3 months in 21 patients of type 2 diabetes-related constipation. They found the change in HbA1c from baseline to week to third month from 7.8 to 7.6%, and their LDL cholesterol levels decreased from 120 odd to 98.5 mg per deciliter. So hence, along with constipation, it helps enhance glucose and lipid metabolism in diabetics and has the potential for treating different aspects of metabolic syndrome. So it was also found to be superior to a very common drug which has been ruling the roost as a second line agent in our practice for the last 5 years or so, which has been procalopride, predominantly a prokinetic for chronic idiopathic constipation. So they studied the efficacy of different pharmacotherapies in constipation patients. The network risk ratio of 1.3 suggests that Elobixibat may be more effective than procalopride, and both Elobixibat, bisacodyl, sodium phosphates were found to be similarly effective, but bisacodyl is well known to cause painful cramps and diarrhea more commonly than Elobixibat does. And it also demonstrated effective outcomes, and it needed to treat three to prevent one bad outcome. So this is very commonly the chart we have been using for any new drug which has been used for chronic constipation. Your number need to treat. So till now, the first line drugs have been polyethylene glycol and lactulose with relatively good number need to treat 2 and 4. The other drugs like lubiprostone has been 4, procalopride has been 6, linaclotide is still to launch in India again around 6. Velucetrag never reached India, and now Elobixibat, the drug 10 milligrams per day, has a very good number need to treat of 3, almost as good as your first line osmotic laxatives. So minimally absorbed and low diarrhea incidence was found compared to other laxatives in this study, compared to lactulose, magnesium compound, sodium picosulfate, and procalopride. Where procalopride, we do know instant diarrhea can be relatively high and means minimally absorbed, hence their diarrhea risk and other adverse events are much lower compared to these other laxative groups. So it's a very reliable and well-tolerated alternative to your traditional group of laxatives. Its benefits over the others are it increases not only motility but also secretion of fluid in the colon and increases your desire to defecate. So drug interactions, it inhibits the PP glycoprotein and minimal risk of drug-drug interactions. Efficacy is above 90% with good spontaneous bowel movements above 3 per week over 2 weeks. And the first spontaneous bowel movement within 1 day will be found in around 80 to 90%, and long-term safety is proven over a year. So to summarize, it's a suitable option for various difficult to treat patient profiles. It is locally acting, which is a major plus point, well tolerated. Electrolyte disorders are very rarely seen with Elobixibat. Elderly safety has been proven now across Japanese studies. Diabetic safety has been proven with additional benefits in lipid metabolism and glycemic indices. Cardiac safety has been proven along with CKD patients. Now 4.5-year data has come out recently, which has been shown to be completely safe in patients of diabetic nephropathy, chronic glomerulonephritis, and other groups of chronic kidney disease. Abdominal pain, it does help to some extent, but can cause pain in up to 5% patients. Bloating, not too much, and no effect on the psychological conditioning of the patient as well, which has been an issue we have been facing with procalopride recently. So thank you everyone for your patient listening, and I think we can go ahead with the discussion with the experts.
Dr. Ranjit Sudhkar, if I can just ask you to help us in moderating this discussion. Dr. Ranjit? Just connect. I think there's some connection problem. Let me just connect with it.
So, thank you, Dr. Pragati. Sorry, I was muted. And thank you, Sukrit, for an excellent overview. And it's a great opportunity that I've got my other colleagues here, Dr. Sanjay Mittal, Dr. Manish Jain, and Dr. Wazir, who belong to different specialties and have different perspective and needs of their patients. So, just to set the ball rolling, I'll go to Sanjay. Sanjay, in your practice, how frequent is constipation? You're muted, I think.
Yeah, sorry. So I love that question because it reminds me of that movie Pico. That the persons with advancing age and cardiovascular disease actually ultimately succumb to because of constipation. And I think although the world literature says about 50% would have constipation, but I think in India it's much higher, mainly because we have a higher predisposition for diabetes as a concomitant risk factor for cardiovascular disease. And the other factor is, as I am dealing with heart failure, when most of my patients are on diuretics and other things. So I think every in two-thirds patients, I would have constipation of one or other sort.
So I may ask you that what is your normal laxative which you give? Because after all, more than their chest pain, they'll be concerned about the bowel movement.
Yes.
Because for Indians, having a bowel movement in the morning is like having Janganman. So what do you normally prescribe to these people?
Yeah, so about the bowel movement and all, it's not so innocuous because uh, I think there was a UK Biobank study when they found that people who had constipation and when they followed up, the incidence of MACE or major cardiovascular adverse events was as high as twice of those who did not have constipation. And there are certain reasons because these people have high blood pressure during the straining of the stools and a lot of other things which can happen. So it's not so innocuous. The risk goes up, cardiovascular events. And in my opinion, I use first lactulose, which is my drug of choice. But the other thing is PEG, as just like we have been educated by you guys much more in our hospital because of that osmotic diuretics and the fact that most of my parents are already on diuretics, which would cause the dehydration of the stool and maybe predisposed to constipation as well. So these osmotic agents possibly would help them to pass the stool much better. So that's what my preferred choice is. I've not been using Elobixibat so much frequently, only a couple of them, and possibly discussing this further in this forum. Possibly we'll change our platform.
Thank you, Sanjay. And Manish, in chronic renal failure patients, again, you restrict their fluids. You dehydrate them during dialysis, and chronic. And then many of them are diabetics, and then hypertensive, and they are on the calcium channel blockers. You must be having a huge problem of constipation in your patients.
So thank you, sir, for giving me an opportunity, and thank you, Dr. Reddy's. So as Mittal sir has told very correctly, so their patients are like this, and our patients are severely like much more problem is there. And though practically in dialysis patient, what we see almost half of the population has this constipation. But if you see more than two-thirds, they will have a constipation. And as rightly you said, they are on calcium channel blocker, which is known to cause constipation, and diuretics also. So almost like two-thirds, and slowly they become ineffective. And in dialysis patient, we can't use milk of magnesia or fruclopride also because of the other risk factors. So again, as the cardiologist, lactulose is our preferred one. But what we see after some time, the lactulose also start becoming ineffective. And as their mobility is not there, and the diet is also not good. So these factors also definitely play a part in that.
Thank you, Manish. And Jasjeet, what about you? Because again, uncontrolled diabetes dehydrates in any case, and then diabetic neuropathy paralyzes the colon. It causes hypomotility of the colon. So, and your patients also are on multiple drugs, including calcium channel blockers for their hypertension. So, what is your need for a good agent for treating constipation? How frequently do you report?
So actually, especially with long-standing uncontrolled diabetes and being at Vedanta, we have a lot of load of patients who are diabetic, have got cardiac issues, and have chronic kidney disease. So one is diabetes per se, the neuropathy, the autonomic neuropathy part of it. Two would be the drugs that we use in diabetes, especially metformin, the GLP-1 based therapies, which are the newer therapies, have a whole lot of GI side effects, including constipation, as one of the most important reported symptoms after neuropathy in our patients. And in the years of experience, we really not fond of using lactulose, and because we've observed a lot of variations in their glycemic control happening. The recent usage of procalamide has been reasonably good, but after the launch of Brixibat, we've had much better responses, much faster responses, and much lesser adverse side effects, as Sukrit had presented. And that part about some benefits by virtue of better gut motility or just relief of constipation translating into better glycemic control is a very big added plus point for our patients with diabetes.
Thank you, Jajit. And Sukrit, as far as the GI practice is concerned, these, the Sanjay, Manish, and Dr. Jasjit all talked about secondary constipation, which was related to the other diseases. We normally come across more of a functional constipation or chronic idiopathic constipation. So, what is your take on this, and what is your preferred first-line treatment for this?
I think for chronic idiopathic constipation, first line still remains, I think, polyethylene glycol for patients who have no issues with fluid intake. Those where fluid intake is an issue, or maybe who are better tolerating lactulose. There's a subgroup which doesn't tolerate lactulose. They have more cramps with it. So we lactulose then becomes a second line for me. And then comes the drugs. Either lubiprostone doesn't do too much for most patients. It's a good add-on drug. But first, then second lines become between prucalopride and elobixibat. Prucalopride comes with own set of issues, be it cardiac safety. It's not the worst, but it's not the best either. If we have something better, we tend to choose that in elderly patients. Suicidal ideation underreported. Psychiatry colleagues do now report that patients who are on prucalopride do get issue with even dysthymia, at least, if not major depression, over usage above 8 weeks. So that's a concern for us now. Yes, as a SOS drug, it still works well, similar to Dulcolax, but for somebody I'm going to treat for now long term, 3 to 6 months or maybe even 12 months, Elobixibat with the current price point is pretty attractive.
So, may I ask you that what is your experience with the Elobixibat, number of patients wise, and their their satisfaction with the Elobixibat?
I think in the OPD now we must have upwards of at least 70-80 patients on Elobixibat. Currently, most of them are upwards of 50 years in age. These are patients who had refractory constipation, have tried everything else. So now that we have a newer drug, we wanted to give it a shot. There's some bias in our mind as well, because we do want to see what it does in this difficult to treat subgroup. But yes, I have been pretty happy with it. Because safety I cannot comment too much on, because it's been a shorter period that we have been able to use this drug. Pretty recent in its utilization. But yes, efficacy is good. Sometimes too efficacious in terms of very premature spontaneous bowel movement in the middle of the night. So timing the drug became an issue for some patients. Some patients have to be given the drug just before bedtime. We are supposed to give it half an hour to 1 hour before dinner, but that changes from patient to patient.
Now, tell me another thing, that would you like to use it as a first line treatment or a second line or add-on treatment?
It will be a second line treatment. First line will still remain osmotic laxatives, over the counter, easily available, cheap. And those are important things always. But yes, second line for most patients. But for patients with significant comorbidities where safety takes priority, it will become first line.
So, Manish, coming back to you. There is some reports that Elobixibat increases the phosphate absorption from the bowel because of vitamin D receptor dependent action, and that causes phosphate absorption. You think that will be increased serum phosphate will be a factor in treating your patients with the Elobixibat?
Yeah, definitely, sir. Serum phosphorus, because this bone mineral disorders goes hand in hand, and as our kidney disease is progressing, this becomes worse. So we have to monitor the phosphorus, but right now I can't comment because already they are on the phosphate binders. So what is happening with this? It's very difficult to comment. Though I have few patients I have put on this drug, So in due course of time, once we see how is the phosphorus going on and whether their requirement goes high, then we'll come to know how it's acting in that way. But as if we see theoretically, definitely it's going to get affected.
There is evidence now available in the literature that patients who are who are just CKD, not requiring dialysis, or even those who are on dialysis, they have a good response to Elobixibat, and because it's not absorbed, so possibly it has no or very minimal, systemic side effects in a patient with renal failure, because that's where the normal clearing mechanism is absent. So that's an advantage which I see in this. And and you cannot use polyethylene glycol because unfortunately that requires water to be given, and you cannot use magnesium sulfate. But Dr. Jasjeet, do you use anthraquinones like Senna preparations? Because a lot of patients are on Softovac and all. So do you use them for long term or short term? Because they're cheap, they're effective.
Most of them would be really short term, but their effectiveness is clinically very, very questionable. We rarely come back patients with satisfactory results, as Sukrit had talked about, the fast action and over a period of time, better bowel evacuation. We rarely find these patients to be satisfied with the treatment. They said, yes, we are feeling better, but that happiness of a proper bowel evacuation is not present, especially in those who've had long-standing uncontrolled diabetes. This drug, I would have possibly used it in about 20 to 30 patients. Uh, Fortunately, none of them have come back with any side effects because it's only very recently, last couple of weeks, we started using it. But my take is the fact that they've not come back with any side effects, that they would be tolerating it well.
So, Sanjay, you have possibly one of the longest experiences in clinical medicine with your patients amongst other panelists. So, I just ask you, more than any other the prescription laxatives, people come back with, these Ayurvedic preparations, like, which are often taken and with a lot of satisfaction in patients' mind. So, what is your take on them? Do you let them continue with that? You discontinue that, and what do you do with that?
That's a wonderful question. Um, Even if I allow or don't allow, doesn't matter because they'll still continue with it because that's what they are tuned up or I mean the condition reflects is that gives them satisfaction. Whether it is effective or not effective doesn't matter, and they are going to keep on using that. So that's something which is there. I obviously, because of lack of understanding, would ask them not to go for those things. But I am sure many of them keep on using those things. I have a question for you and Sukrit. You know, for us and probably Manish as well, deal with heart failure and he deals with renal failure. Constipation is a handicap because it potentiates one more thing, which is hyperkalemia. And one of the things which we are very scared about is hyperkalemia holds us from using ARBs, ASRNs, and other drugs which are so very important for heart failure and even renal failure. And one of the things we do is to make sure constipation doesn't happen, rather to the extent of loose motions. So one is this thing, and the secretory drugs probably, in my opinion, would lead to more potassium loss and reduction in potassium. That's why I was intrigued on knowing about the secretory component of Elobixibat, along with the other osmotic constipation relieving substances. The other thing is, I was also having a concern about the elevated risk profile seen in heart failure patients. So, your comment on these two things?
You see, Elobixibat, as Sukrit mentioned, has a dual action. When it basically it prevents bile salt absorption in the ileum, the bile acid transporter inhibition happens. So there are more bile acids available in the colon, and that causes osmotic reaction, and that causes secretory diarrhea. Plus, it also improves the motility of the bowel. So it has a dual action. So it does lead to secretory action. But having said that, I'll tell you, I have seen that for patients with hyperkalemia, lactulose possibly is quite effective, because that leads to significant potassium loss, because it causes significant irritation of the colonic mucosa, and makes it lose potassium. So in fact, when we give lactulose to our patients of cirrhosis, hypokalemia is one of our risk factors which we keep a watch on. So the other thing with lactulose in such patients is that you do not have to bother about the volume, because you don't dilute it with anything, and you don't chase it with water like polyethylene glycol. So that's one addition. And see, the problem is there is paucity of data. There's nothing like not combining lactulose and Elobixibat, and because that can also be done for having optimal outcomes in these patients. So I think with the time and experience will tell us whether as a add-on drug, these will be more beneficial. And you had another question. I
was
lost.
talking about the risk profile in the study, with small study, but the risk was higher in heart failure patients of using.
There's Elobixibat. Was there any higher risk in heart failure patients?
Yes.
So, Sukrit, you comment on that, and why was that? Was there an explanation for that?
No, there was no explanation per se, but this was a very bad group of heart failure. These were bedridden patients that they had chosen. These were hospitalized heart failure. So most of them did have baseline, but possibly bowel edema as well. And these are the patients who end up having more pain and more diarrhea in across the board. So even hypoalbuminemics, they were saying that these patients tend to have more of cramps. So even in cirrhotics, when the study happened, they had more of pain as an adverse event rather than diarrhea.
In fact, there is one comparative meta-analysis of comparing, lubiprostol, linaclotide, and Elobixibat, published only late last year from Satish Rao, who is a very eminent, luminal gastroenterologist in US. And that clearly showed that Elobixibat, compared to other two, has higher incidence of pain abdomen. So that's one area where I would avoid giving Elobixibat. If a patient comes with constipation and has pain, I would rather avoid Elobixibat. And but it has one good thing, that it has the least potential to cause nausea. And many of the CKD patients have nausea. So and same thing with the CCF patients. So that becomes a plus point for it. The patients who have got baseline nausea, maybe Elobixibat will be a better drug. But if they have pain, I'll avoid them. Sukrit, your comments on that?
I think the fact that it's a prokinetic as well, indirectly due to the bile acid, not only irritate the lining, they also cause action on the FGF receptors, which cause the prokinesis. So any prokinetic would be expected to cause some pain, because if the bowel is not completely healthy, or there's a lot of fecalis, or there's a lot of holdup, the patient, like prucalopride, causes pain as well. The pain scores can be pretty high in the study that they did comparing the two drugs. So prokinetics by nature are known to cause pain. Same thing used to happen to Dulcolax patients. So it's expected. Pure secretagogues will not cause pain.
So Jasjit, for you, the thing is, I'll come to your. Please go ahead with your comment first.
No, sir. I had a question in my mind. In today's date, in the advancement in metabolic medicine, we talk lots about gut microbiota as a causative and a therapeutic arena for chronic diseases. I'm intrigued and would really like to know the impact of this particular drug on the gut flora. And is it any way related to how it leads to a better A1C reduction? Because a 0.2% A1C reduction is actually very, very significant for any drug.
There is some initial data, because you must understand this drug is commissioned in Japan, and predominant evidence is from Japan. There are only some evidence from Europe, and it is not yet FDA approved, so you won't get any evidence from the USA. We have done before pre-marketing trial in India on Elobixibat. So all these questions are not yet answered, but there is some evidence that bile acid metabolism positively affects, means if you provide more bile acids, then positively affects the gut microbiome. And maybe it is related to that. I don't know how does the HbA1c comes down. My question to you was that you in your practice with the particular diabetics, the diabetic colopresses and autonomic neuropathy is a very important factor. So do you use prucalopride very often? Because that drug's major point was that it has a prokinetic effect, and particularly it was started in diabetic patients.
We in the recent past, after its introduction, were using the drug pretty successfully, and in the cases where the constipation was becoming a big problem, we had our department really taking care of. Sukrit, in fact, has a lot of the are such chronic patients. I would actually refer it to them. So in the milder cases, definitely we would use these drugs, and but their persistence on therapy was very poor. And one point which Dr. Mittal also raised about these so-called churans and all, they are just stuck onto that, and despite us not knowing what components they have, they just want to continue on those medications without understanding the possible impact on their health. But yes, we have been using those drugs pretty often, and patients are tolerating it well.
You see, in fact, most of the indigenous medicines which are used, like Trifla or these all these tablets, they are local irritants. They are irritant laxatives, and they are good for short term, but we don't know their safety long term. And so that is the basic concern. It's not only their ability to be effective; it's their whether they are safe in a particular clinical setting. That's where we lack evidence.
So, yeah, one thing is important is that Kayam churn is just like what you said, they persist with it. And I do not know what is the salt content of that, what is other things which can lead to a little bit of retention of fluids. So I always say, please don't take it. I'll give you a medicine, or I'll refer to my colleagues, you and Sukrit, either of them. One question which I have, or suggestion, or concern which I have is, yes, we have been talking about LDL reduction and something which is good, but and so has been other bile acid sequestrants. Cholestyramine was one of the drugs which was used for cholesterol lowering. But I am sure that cholesterol lowering, LDL lowering by such agents did not result into the mortality benefit, MACE reduction. It is only statins, because of their certain other effects, which have been responsible for reduction of cardiovascular events beyond the LDL reduction. So yes, it's good. It's something to be observed for, but we'll have to wait for the hard outcomes to say whether LDL reduction is of significance.
You see, so far it's just an observation.
Yes.
It has not been related to any health benefits. So both in terms of HbA1c, and that's a single arm study on a very small number of patients. Similarly, LDL decrease and HDL increase. You see, it's like this also happens with this drug. That's whether it leads to additional health benefits, we still do not know. So coming back to the drug, because most of the experience is with gastroenterologists at present. So, Sukrit, what is your practice, of prescribing Elobixibat? When do you give it, in terms of how many milligrams, and what time of the night or day, and how do you titrate it?
As of now, I'm using it like a second line drug for most of the patients. Either they are refractory constipation or have failed on osmotic laxative, or the comorbidities are limited. So I still start most of the adult patients at 10 mg dose. You get the 5 mg formulation. So two tablets, half an hour before dinner. You start at that half an hour to 1 hour before dinner and ask them that should be around 8:30 or 9 o'clock in the night, because the spontaneous bowel movement will hit anywhere between 5 to 9 hours. So they should not be woken middle of the night, or elderly patients soiling themselves. So that is a concern. But that is what I practice. And if they report premature defecation in the middle of the night, then I have to modify the timing of the drug. And rarely
So,
we have to upstep the dose also. For out of these, I think 10% patients have needed 15 mg dose in refractory constipation.
how frequently did you have the need to downside the dose? Because some people may complain of diarrhea with 10 milligrams. So in practice,
I've had patients who had actually had very occult IBS like constipation, predominantly theme like functional constipation, but they had a baseline discomfort. They were the ones who needed downstepping rather than the diarrhea component. They were the one who had some discomfort was worsening, and then they would need more antispasmodics. For the same, it became like rather than giving two drugs, we decrease the dose or take them off completely. So, couple of patients we took them off Elobixibat for the pain component.
so tell me, how long have you given it and how long is the recommendation?
Recommendation right now is for 8 weeks. 2 weeks is what the drug company is told to give. The Japanese guidelines say 8 weeks is safety. Safety has been proven up to 1 year. In across the board for renal patient, we have a recent data on 4.5 years also. But I haven't used it for more than 2 months in any of my patients yet.
So what is your practice? You shift to another agent, or because constipation is not going to go away? It's
No, actually, my practice is 2 weeks we give the full dose. Then you try to down titrate them if they're doing okay. And if they continue to do well on the 5 mg dose, you can bring them back to the osmotic laxative, or a combination of a low dose Bixibat with osmotic laxative, or we don't need to take them off completely. If these are patients who have been suffering for a while and there's no hard data that we need to toe the line or take them off in terms of safety repercussions.
So Manish, your take on this, and how do you
Actually, I've
teach
given
you?
this to my dialysis patients. So along with lactulose, and two, three were very happy after this. So there is like two patients whom I have withdrawn the lactulose and given this drug only. So they were
Okay.
also thought, since it is they are responding. The only thing what I found out, they were getting dry mouth was much more frequent with when we were using this, because already these patients are on clonidine also are coming, and other diuretics also, and during dialysis they loses water. So this was the thing which we've seen. But my concern was same, like I want to know from both of you. These are the patients who will require lifelong drug, because some many patients, they don't have a movement, or they become like, once we tell them you have to be on dialysis, so that bechara is feeling is there, and they don't do like slight efforts also. So can we give it lifelong, like, because especially after dialysis they want to take it. So
See,
what?
lifelong we still don't know because the life of this medicine is very short yet.
Yes, sir.
So the thing is that 4.5-year data is available, which where the safety is there, so and efficacy is there. Good thing is that it does not have tachyphylaxis, and it did not have a toxicity profile which will prevent you from giving it. Over a period of time, yes, we might get evidence that it can be given longer. And then my practice is that, as Sukrit also told, that I'll switch,
Yes.
and because apart from the medicine safety, cost becomes an issue with many patients. So you try to see whether you can go over to some cheaper alternative. So and that is always the stimulant laxatives which are cheapest. So we can switch between these.
This is the best
periodically.
practice, sir. I
Yeah.
think, sir, we can give this for 2 months, like 8 weeks, as Sukrit has told, and then we can give a gap of few weeks. We give them lactulose or something, and then again we can switch over them according to the response.
So Jasjit, what about you? Because we would like to have your views and then try to get the wrapping up of.
Actually, I have learned lots about the chronicity of the treatment. because we always used to get stuck in what to do next. And at times, patients are also reluctant in traveling to other specialities. So this is a very important part, which I would be definitely inculcating in our practice, because as I said, after neuropathy, constipation is possibly the most important symptom. To have this graded changeover of medications, very well respecting the fact that cost of medications is a very important part of its out-of-pocket expenditure. So do that and apply that for the best results for our patients.
Thank you, Jasjit. I think if we talk of actually this is very interesting. When as gastroenterologists we normally look at the constipation, chronic idiopathic constipation or functional constipation, and that percentile is only 11 to 16% of the general population. But when we are talking to people like you, then it's almost majority of your patients have constipation as the major complaint. So secondary constipation we see when you refer them, but you see it firsthand. So I think a molecule which is not absorbed, which acts locally and has the potential to give a spontaneous bowel movement very early. In fact, the meta-analysis which I was alluding to did compare Elobixibat with lubiprostol and linaclotide, and it was Elobixibat which had the fastest onset of action and the highest percentile of patients with spontaneous bowel movement as compared to others. And I think this molecule has certain advantages, and its safety so far over whatever period we have seen, at least in Japanese population, we know the evidence. In Indian small group of patients, we know the evidence. And I think as when we are having phase 4 evidence of when it's being practiced now, we may become more confident of prescribing this molecule in various comorbid states. So Pragati, you are there. So you want to conclude? I would like to thank my panelists tremendously because of their contribution to today's proceedings.
Thank you, sir. So just before we conclude, I will just check if we have any questions from the audience also. Though I think all the questions that I've noticed till now have been answered. So let me just have a look. Till now, if we can have some comments from our panelists, the final comments that they would like our audience to take as a take-home message. So, sir,
Sanjay,
maybe we can start with Dr. Randhir. One point each from your specialty, if I can.
No, I have talked enough. I think Sanjay wanted
Dr.
to say
Sanjay,
something.
I just wanted to say one thing. I'm a cardiologist and heart failure. I have so many patients with constipation, so I limit myself to lactulose, or maybe one more thing. The moment they don't respond to that, I prefer to send them to a gastroenterologist to rule out some other thing which might be developing. And I think I should not cross my line. As a physician, as a cardiologist, my duty is to treat with the safest one, and then once it is there, I refer them to Dr. Randhir or Dr. Sukri.
thank you so much. Dr. Manish, your
Actually, for us, like as Dr. Vajeev was telling neuropathy, but for us, constipation is the most common thing which we face. And the patients are, frankly speaking, reluctant to spend money because of the other supplements. And in kidney patients, because of potassium or whatever, we can't give all these students and other things. So I think we can have our own trial with Sootsar and Sukrit, along with like we can see like 1:1 our dialysis patient, and we can create our own data also on this molecule. So I think that will be a good thing. And in that way, because like if this is a good one, that will be a benchmark.
thank you, sir. Dr. Sukrit, any points from your side?
I would not go beyond saying it's like a savior of our times, but it's been a good drug, good tool to have in armamentarium. It's almost like a get out of jail free pass for a lot of our patients who have been struggling with constipation for a while, and we have been struggling with what to give them. So we are happy to have this as an option, and hopefully in the future the cost can be further brought down so it can reach more patients.
Thank you, sir. Dr. Jasjeet, your parting comments.
So I deeply appreciate and thank Dr. Sood sir and Sukrit for making me wiser, and through that, hopefully making our patients much happier, getting them relief from this very important thing of constipation, which really troubles them. So, a really big thanks to Sir and Sukrit.
Dr. Reddy, before we close, we have all the specialities here. There's one question that we would prefer our gastroenterologist to answer: the use in CLD patients. That is one of the questions that has come. So if you can just put your point forward and then maybe post that, we can just have a.
See, we are using it in CLD patients, but most of the CLD patients, particularly when they are child B or C, they'll be on lactulose. So they will not be, because lactulose has other benefits in them in lowering serum ammonia. So but it is okay as a constipation medicine in child A cirrhosis or early child B cirrhosis where the lactulose is not required. But once the lactulose is required, adding another molecule doesn't make much sense unless patients on lactulose are requiring very high dose of lactulose and you need to add on some other medicine.
Thank you so much, sir. I would love to thank all our panelists and for giving us time today. So I do realize it is a very busy day for you. So thank you so much for taking out time from your busy schedule and getting together with us. It was very helpful for us to understand the Elobixibat point of view from various specialities, because till now we have had a lot of connect with the gastroenterologist, but yes, a lot of other things are also there. So thank you so much. And I would also like to thank our audience for today for taking out the time. Thank you so much. Have a great
Thank
day ahead.
you.
Good
Thank you,
night.
everyone. Have a good night.